Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today in the show, we have Drew Reminanti. He is an emergency physician, and he wrote the Kevin MD article, Only Patients Can Save U.S. Healthcare. Drew, welcome to the show.
Thanks for having me, Kevin.
So we'll get into the article in a little bit, but first off, can you share your story and journey to where you are today?
I'll start with the end. I retired in April of 2020 after 40 years of practice, having graduated from Rutgers Medical School in 1980. And I can honestly say the pandemic did not drive me out of the emergency department. It just happened to be coincidental timing. I had become board certified for the fourth time in 2014, and I did the math. The next time I would have to recertify was 2024, and I'd be 71 and probably a hazard to my patients. So 2020 seemed like a nice year because it was a nice around 40 years.
So you mentioned that you've been an emergency physician for 40 years now. What are some of the biggest changes or trends that you've seen over your decades of emergency medicine practice?
Certainly the biggest and most distressing is the fact that when I did my residency training, our faculty said, you got to get efficient because when you leave here, you may be in a solo physician emergency department, which it turns out I was. So you have to keep an eye on the entire department and how things are running so you don't overlook something. So you have to be efficient. But the idea of being productive, the word they use all the time now, was never mentioned. So that's the most distressing thing because almost everything is based around the idea of getting people through faster, being productive. It's an unhealthy emphasis, I believe.
I certainly see that word productivity in primary care in my internal medicine practice a lot. As it relates specifically to emergency medicine, what does it mean to be a productive emergency physician in your eyes?
They actually keep data on how many patients per hour you see, which is a somewhat useless piece of a number because it depends on the severity of their presentation. But they just average over the course of weeks and months and years, and they say that reflects what you're doing. The problem is the pressure is to move faster, see more patients, see them more quickly, keep them satisfied, and get them out of the emergency department so you can move some more. And I think it's cart before the horse.
Mm-hmm. Now, during your practice, how was that pressure relayed to you? Were you taken aside for meetings with the administrator and given spreadsheets of how many patients you saw per hour? How did that affect you when you were practicing emergency medicine?
Yes, essentially every year when you're on your annual review, those figures and data were brought up and you would be compared to your coworkers and where you fit. And I remember, I won't go through all the details of it, but just briefly, I had a patient that my physician director said to me, try to pick up just one more patient at the end of your shift and, boost your numbers. So I picked up this patient, which had very minor complaints, was about to send him out of the emergency department. I asked him one more time, what is it that worries you? Well, you see, what it is, doc, I'm a hemophiliac. I'm afraid I'm bleeding in my brain, which was entirely unrelated to everything else he had told me. I mean, I knew he was a hemophiliac, but no head trauma, no. So I reluctantly ordered a CAT scan just to get that done. And sure enough, he had blood all over the right hemisphere of his brain. Mm-hmm. So that's the kind of thing that made me angry because I would have missed that had I not made myself slow down a little bit and they asked that last question. I told that story to my emergency department director, and I was expecting him to say something like, gee, that's surprising. And I'm glad you work at the right pace, Drew. He did not say anything like that. He said, well, he went back to the productivity issue. And I said, look, I practiced to my own level of I practice to my own standard level. Some things are fast and slow things are slow. And it's up to me to determine what I can move fast with and what I can move slow. But it was a constant pressure.
And from your experience, the people that are measuring productivity numbers from the clinical staff, do they themselves have any clinical experience? Were they former physicians or were they purely MBAs, administrative types?
In the places I worked, they were all board certified emergency physicians who had been doing, initially before they came into administrative positions, were exclusively clinically practicing. But I think it's one of the fantasies of a lot of physicians in clinical practice is how can I get out of clinical practice and make similar or more money? And when they asked me for feedback about how I thought they could do their job better, I said to them, you really need to be a clinician first and an administrator second. And I think they lost sight of that at more than one institution.
All right. Let's talk about the Kevin MD article that you wrote. It's titled, only patients can save U.S. healthcare. Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
This addressing the same frustrations. The people who are in position to make changes, like the people in politics, the government people, are really not motivated to make a change because most of them have gold-plated health insurance policies, so they don't see a problem. They're not going to worry about how they're going to get bills paid. Hospital administrators and who can make decisions in that regard are getting 6 and 7 figure or 7 and 8 figure salaries per year, income per year. So there's no motivation to change the system.
Mm-hmm.
So trying to retain some optimism, I'm a reflex optimist, but trying to retain some optimism, I thought, well, you as a patient, me as a doctor, we can't change the system individually, but together we could change how we're going to operate. And I think that gives us some power that outside the hospital. And in the second link I put 3 links in my article. The first one references a study in which showed that the hospital administrators trying to keep patients happy showed that patients who reported greater satisfaction with their care actually had higher expenditures for both more hospitalizations, higher expenditures for hospitalizations and drug costs, and shockingly actually had a higher mortality rate.
Mm-hmm.
It was just one study, and I don't think being satisfied makes you more prone to die.
Mm-hmm.
But I think what makes you more satisfied is getting more services, and more services can sometimes lead to complications which increase your mortality rate.
Sure.
Then the second link I have in there is to a hospital administrator, which is people should really read it just to read that part alone.
Mm-hmm.
I have to admire her honesty in which she frankly says patients need primary care, but they don't need a primary care physician.
Mm-hmm.
So she was saying out loud the quiet part, which is hospital administrators are constantly telling you that service to the community and the value they're bringing and patients' welfare is their top priority. And then they're telling you things about increase your productivity, which addresses none of those things.
Mm-hmm.
So she said out loud that patients don't need or want primary care physicians, and we're going to address their consumer-driven wants. So basically, they want to get the physician out of the equation because by communicating directly with the patient, they can sell more services.
Mm-hmm.
So that was pretty distressing.
So let's talk about patient satisfaction. Tell me how that influenced your career in emergency medicine. What's the role of patient satisfaction when you are in the emergency department?
Well, what I want is patient understanding of what I think we've identified as the problem. I want them to understand what we're thinking jointly and adopt a joint plan on what we're going to do to address that. Mm-hmm. Keeping them satisfied was really nothing that enters my brain when I'm talking to them. Understanding, the kind of things that satisfy people are, getting seen more quickly, getting seen more cheaply, and getting rid of their discomfort. And of course, I'm always trying to address their discomfort. Mm-hmm. And I'm trying to be efficient. But that CEO is interested in patient-driven wants, not needs. Mm-hmm. And that's a telling distinction right there.
Sure. Now, was patient satisfaction one of the metrics that you were measured for during your time?
Oh, yes. There's Press Ganey, which I'm sure you're familiar with, the Press Ganey reporting. And, basically they ask a series of questions about your emergency department visit, many of which are towards things that I have no control over. How long did you wait? Was the nurse treating you well? Those sorts of things, which I have no control over, but those things devolved into a number that was applied to me in regard. And annual bonuses were definitely tied directly to patient satisfaction on the Press Ganey questionnaires and also on your productivity.
Sure. Have you heard of stories where emergency physicians would let Press Ganey scores influence how they practice medicine?
Everybody is aware of it, and I think indirectly, some of the colleagues I worked side by side with, I thought made more rapid decisions than I felt comfortable with in order to get those better scores. Mm-hmm. And someone quoted to me once some feedback they got from an administrator that perhaps she should be a little more liberal with using narcotic pain medications because that might keep the patients more content, which of course has led to our opioid crisis that we're in the midst of still.
So when you hear things like that may be implying that prescribing more opioids may keep patients more happy in hopes of increasing patient satisfaction scores, how does that make you feel?
Well, it's incredibly frustrating. And the only ways I was able to complete 40 years of practice was that comment that I made to my emergency department director. I'm going to practice to my own level, my own standard of practice. and I never took into account how it affected my bonus.
Mm-hmm.
So you just have to practice to your own standards, I believe.
So what's the path forward here? So I've heard many of your issues that you bring up. A lot of physicians also bring up similar issues, and they propose a variety of solutions. But I want to hear from you. If you were in charge of our healthcare system, what would you do to solve these problems that you bring up?
I often joke to my colleagues that if you gave me all the power and all the money in the world, I couldn't solve our U.S. healthcare system problems.
Mm-hmm.
I don't think I could, because I think they devolve into a one-on-one with patients. I think we need to become more involved, active, engaged patients. And that's why I'm appealing to patients I'm characterizing it as a partnership. You need to care as much about your health and your results as I do, and we need to work together towards a goal. You're the expert in how you feel and what you want to accomplish. I'm the expert in, is that a reasonable goal, and how do we get you safely there?
Now, what are some specific ways we can do that? How can we appeal to patients?
I worked at part of my strong feelings about this whole set of questions. I was a patient for much longer than I was a doctor. I became ill with the chronic disease of ulcerative colitis at age 19, had that all through college, medical school, and my residency training, and then multiple hospitalizations in regards to that. And that was all capped off by having a stroke in 1992, as felt to be a coagulopathy secondary to my ulcerative colitis. So I was out of emergency medicine for 5 years, from 92 to 97. And in that period of time, worked in occupational medicine, urgent care, and did some community health service work as a physician. And so I can't really speak to what you have to face as a primary care doctor, but I would consider, and this might be the failure point of my practice, directly asking patients to be as engaged in their healthcare as I am.
Mm-hmm.
And I would give them the obligation of being mini experts in the 2 or 3 chronic conditions that they have. And I said, at a certain point in one of our visits, I'm going to give you a pop quiz. I'm going to ask you what medicines you're on, and you need to be able to give me the names, the doses, and why you're taking them.
Mm-hmm.
And I'm sure I would lose a significant portion of my patients for that approach. But I think we really need to hold patients more accountable. And I never tried that, because at that point, when I was in the community health center, I was trying to rehabilitate myself to emergency medicine.
Mm-hmm.
And I was dealing with a relatively unsophisticated patient population, which was an additional challenge.
We're talking to Drew Repinanti. He is an emergency physician. He wrote to Kevin in the article, "Only Patients Can Save U.S. Healthcare." Drew, for those emergency physicians that are still practicing today, and I'm sure that a lot of the pressures that you described is only getting worse, what kind of pieces of advice do you have for these physicians today?
It would be the same thing I mentioned a couple of times about determining what your own standards of care are and practicing to that level of standard, regardless of how it affects your employment, which is easy for me to say now that I'm no longer employed. But it was the approach I took during the last 13 years of my career when I worked in a very busy hospital emergency department.
And if physicians wanted to push back about some of this administrative oversight, and I know specifically in emergency medicine, you guys have some unique challenges with, for-profit, venture capitalist companies purchasing emergency department that includes like a whole host of issues. What are some ways that emergency physicians can push back about some of their loss of control over the profession?
I still participated in an emergency medicine Facebook group called EM Docs, and there's been some conversation back and forth about whether we should unionize as physicians in general, and specifically as emergency physicians, to combat that multi-hospital group problem. And I think it may come to something like that, where you actually have to be willing to put your job at risk in order to make changes, which is hard to do when you're established in a community, have a family, and it means being willing to possibly be fired because you're a squeaky wheel.
Mm-hmm. And when you talk to other physicians in this emergency physician Facebook group, in general, what's the general appetite for doctors in general taking that type of risk?
I don't have a good feel on the pulse of that. I've seen it bandied about, but I think, again, it's understandable that people are not ready to, get quite that aggressive. So I don't see it happening anytime soon. Although I saw an article come across my email about the Stanford residents have just recently formed a union in order to stand up for their rights. So it may happen at the training level. This interns and residents make the first jump, and then perhaps that'll motivate the more established physicians to follow the same. One quick comment: I've been doing a lot of research on these topics, so I'm hoping to try to create a book-length presentation on this, which is maybe a little bit of a pipe dream. And in communicating with an agent recently who already was representing a physician author and wasn't interested in picking up another one, and she said, gee, there should be a forum for physicians to communicate and see how they can address this problem. Mm-hmm. And I did write back to her saying, that's operating under the assumption that we're still steering the ship. Physicians are not steering the ship. Mm-hmm. I think most non-medical people think physicians are in charge and why can't they make it better? And they're making all this money, and all the money that's being made in healthcare is going to people at the administrative level, and it's not going to your frontline physicians.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
I guess it would be that try to take on the challenge with your patients to see whether you can get them to take more responsibility by referring to the interaction with them as a partnership. Mm-hmm. We are forming a new company. The partnership and the subject matter of our partnership is your health. You have to be as committed as I am.
Drew, thank you so much for sharing your story, time, and insight. And thanks again for being on the show.
And thanks for having me along, Kevin.